Hello, and welcome to Why Do We Do That, a psychology podcast that deconstructs human behavior from the perspectives of social scientists, psychologists, and others that use applied psychology in their work. I'm your host, Dr. Ryan Moyer. In this episode, I sat down with ADHD expert Dr. Stephen Faraone. Stephen is a distinguished professor in the Department of Psychiatry at SUNY Upstate Medical University, a senior scientific advisor to the research program Pediatric Psychopharmacology at the Massachusetts General Hospital, and a lecturer at Harvard Medical School. He's an author on over 1,000 journal articles, editorials, chapters, and books, the editor for the journal Neuropsychiatric Genetic, and the program director of the educational website ADHDinadults.com. Stephen is president of the World Federation of ADHD and was a founding board member for the American Professional Society of ADHD and Related Disorders. He has also been inducted into the CHAD Hall of Fame in recognition of outstanding achievement in medicine and education research on attention disorders. His other honors include the SUNY Upstate President's Award for Excellence and Leadership in Research, the Chancellor's Award for Excellence in Scholarship and Creative Activities from the State University of New York, and the Lifetime Achievement Award from the International Society of Psychiatric Genetics. One of my main takeaways from my conversation with Stephen was that the lay public's narrative of ADHD can be very different from that of the professional community. For example, there seems to be a lot of fear associated with the stimulant treatments of ADHD from parents of children with ADHD and adults with ADHD. After my discussion with Dr. Faraone, I felt that a lot of this fear is misguided. ADHD can cause some serious problems in school and in one's personal life. And the bottom line is that the medications that we have are by far the most powerful tool to address these issues. As Stephen points out, fearing adverse outcomes from stimulant medications must be balanced with consideration of the adverse outcomes from inaction or from focusing on weaker approaches. Moreover, behavioral interventions have their place, but it is often the case that medication might be needed first to allow for the behavioral interventions to be applied in the first place. My conversation with Stephen revealed that some of my own thoughts on ADHD were in reality myths. If you have ADHD or have children diagnosed with ADHD, this discussion should help to clarify some ideas and give you a framework for understanding how ADHD manifests and how it can be treated. Enjoy. Okay, today I am joined by Dr. Stephen Faraone. Thank you so much for joining me this morning.
Happy to be here, Ryan.
So today we're going to be talking all about ADD or ADHD. Why don't we just start by talking about the defining symptoms of someone that is diagnosed with ADD or ADHD?
That is a great question, Ryan. And it's really very important because people need to differentiate what are the defining symptoms and then what are other problems people may have. Because sometimes people hear, oh, people with ADHD have anxiety and they're anxious and they think they have ADHD, but they don't have the defining symptoms. So I'm glad you asked that question. Defining symptoms are pretty straightforward. There's three categories. There's inattentive symptoms. People get distracted easily. They partly it's not being able to organize their lives because they can't pay attention to this or that. Hyperactivity, most prominent in young kids. They kind of run around like they have a motor inside of them, climbing on furniture, very, very active. It's less so for adults and older adolescents. They tend to be more maybe fidgety or uncomfortable in situations where they have to stay seated. And then the last category is impulsivity. That's acting without thinking. If you're a little kid and you're chasing a ball, you might run into the street to chase the ball without looking for cars. If you're an adult, you might impulsively break into a conversation without waiting for your appropriate turn. So these three symptoms, I'm sorry, these three classes are actually in the diagnostic manual turned into two sets of symptoms: the inattentive symptoms and hyperactive impulsive symptoms. And to meet criteria for ADHD, you have to have either 6 of 9 inattentive symptoms, 6 of 9 hyperactive impulsive symptoms, or you could, of course, have both sets of symptoms as well.
Mm-hmm. Now, would you say that there is sort of an essence of the ADD symptoms? I've heard sort of working memory is sort of implicated in sort of something that explains why individuals with ADD are impulsive. I've heard that time management is sort of this. I'm trying to get it sort of like a unifying principle that describes the experience of somebody with ADD.
That's a really okay. So let me. I'll get to that. One thing I should point out about the symptoms, when we in the mental health field talk about symptoms, we're talking about behaviors that lead to impairments in real life. So it's not simply somebody's fidgeting a lot. If it doesn't affect them in their real life, it's not a symptom. It's just something that they do. So to be diagnosed with ADHD, you have to have symptoms that cause real life problems. And by the way, those symptoms have to have started before the age of 12 to meet the criteria. You have raised the point about what causes these symptoms. Is there one central organizing theme that we can put around that? Lots of things have been proposed. You mentioned working memory. Disinhibition is another one. I'd like to, when I think about trying to help people with ADHD understand the central thematic nature of their symptoms, I like to appeal to Russ Barkley's concept of inability to self-regulate behavior, cognition, and emotion. At its core, ADHD is a problem of self-regulation. If you think about it, as little children, we all have trouble regulating our behaviors. In fact, our parents have to tell us, do this, do that, don't do this, don't do that. Our parents are essentially in control of us. As we get older, we learn to self-regulate. We stop doing things that little kids do. We inhibit our behaviors in situations where it should be inhibited. We express ourselves appropriately when we should express ourselves. People with ADHD don't develop at the same rate this ability to self-regulate. And this is why when we talk about the symptoms of the disorder, we say that the symptoms are inappropriate for the person's age. So at age 2, running around and climbing on furniture is pretty normal. And defining that as being atypical is something only a trained person can do. But the sense of dysregulation is, I think, a key way to think about ADHD. And adding to that, it's you have to remember that the environment also imposes upon us the need to self-regulate, and different environments do that differently. If we're just lying on the beach, let's say, there's not much to do. There's no real pressure to self-regulate. But if we're sitting in a classroom, there are a lot of pressures to self-regulate. So there's also this interaction between your ability to self-regulate and what the demands are in the environment.
I see. So I'd like to talk a little bit about something that you just mentioned, which is there has to be some sort of impairment like that. That is, it seems as though that's one of the differentiators between what you might call normal inattentiveness versus being diagnosed with ADD. But as soon as I hear impairment, I start thinking, well, impairment is part on the individual, but can't you attribute some of the impairment in quotations to the environment? So for example, if somebody with ADD is having trouble at home or school, what role does the environment play in terms of, what happens if the expectations are too high for that environment? I mean, we expect children to sort of sit in desks quietly for 8 hours a day. I mean, I feel like that's too much for a normal brain, let alone an ADD brain. How do you look at this conversation around, well, society or our norms, our institutions need to be more flexible with respect to our discussion around individuals with ADD?
Well, relevant to your question, I'll first point out that to be diagnosed with ADHD, the problems you experience, the symptoms you experience, have to be evident in more than one setting. So if they only occur in school or only occur at home, it's not ADHD. It's a problem with that environment. No question about that. That's really important. ADHD is not situational. It doesn't just happen when you're with your wife or when you're with your parents. It expresses itself in multiple situations, and that's a requirement. Your question also raises the concept of accommodations. To what degree should schools or society in general accommodate to people with ADHD or people with other mental health problems? I think accommodation is very important. I mean, if you consider when I was young, society did not accommodate well to people who had to use wheelchairs to get around. And those people had much less ability to be out in public. Nowadays, because of laws, because of people realize we need to accommodate to physical disabilities, people who have to use wheelchairs can get around in many settings. Of course, the question becomes how much does one accommodate and in what settings? And that leads to a lot of more complex issues. It's also raises issues for schools in terms of what they can afford in terms of funding, because if accommodations require, for example, smaller classrooms or special teachers, there's a price tag associated with that. So society has to decide, are we going to pay the price? Now, I think we should, but I don't make those rules, fortunately.
Right. So let's jump into the causes of ADHD. Sorry, I keep going back between ADHD and ADD.
Well, let's stop there for just a minute, because that confuses some people. The reason why these two terms are around is because in the early 1980s, when we came up with the really first good diagnostic criteria, the disorder was called attention deficit disorder, with or without hyperactivity. So with ADD, with or without hyperactivity, and it became known as ADD. And then fast forward, in a later revision of the diagnostic manual, they decided to call it attention deficit hyperactivity disorder, or ADHD. So today, the correct name is ADHD, although we hear ADD used all the time, particularly in the popular press and the internet.
So that's a great comment. It strikes me that there has been a lot of changes in terms of the diagnostic criteria, the language around ADHD. Could you highlight some of the major changes that have been implemented with respect to the diagnostic criteria? Are there some things that are just plain, we used to understand it this way, and we've completely shifted our understanding? Are there any big things that we would be interested in learning with that respect?
The only really big shift occurred in the early 1980s when the whole diagnostic manual changed, where the diagnoses were vaguely described. There wasn't detailed symptoms as I described, detailed criteria. In the 80s, it was it was not so much that we changed who was diagnosed with ADHD, but we did a much better job in terms of improving the validity of those diagnoses. I'm saying we, I didn't do it, but we as a field did that. Since then, changes have been relatively minor, with the exception of the new fifth edition of a diagnostic manual in the United States, which particularly changed a little bit how we diagnose ADHD in adults. Made it a little bit easier so that an adult with ADHD only needs to meet 5 symptom criteria in a category as opposed to meeting 6 for children. And that's because myself and others have found that with age, the symptoms of ADHD tend to attenuate, even though they can still be very impairing. But that was really one major change in the DSM. And the other major change was that the DSM recognized that and by the way, DSM is short for Diagnostic Manual. The DSM recognized that the symptoms in adults are sometimes expressed differently. So as I said before, instead of being frankly hyperactive and running around, adults can be uncomfortable in situations requiring that they sit still.
Okay. Now, it seems as though that there is both a genetic component and an environmental component to that contribute to the onset of ADHD symptoms. Could you just sort of broadly talk about how we should understand the dynamic between the genetic influence and the environment?
Sure, absolutely. First important fact, we know from decades of twin studies, there are over 30 now, I think, that the heritability of ADHD is about 75 to 80%. What that means is that we can explain 75%, 80% of ADHD in the population by genetic factors. That's very clear. And we know to some degree what those we know a little bit, I should say, about what those genes are, and that's we could do a whole podcast on that. Mm-hmm. The environment has a smaller role, and the environmental risks have been much more difficult to establish with certainty, and that has to do with some technical issues of how one designs research projects. Genes are very well behaved. It's very easy to take a DNA sample from somebody, assay their genes, and understand that there's causality. The environment is much more difficult. So there are really, in my view, only two environmental risks that are clear causes of ADHD. One of them happens to be severe traumatic brain injury. That can lead to, that's a rare case, a rare cause of ADHD. And the other extreme deprivation early in life, which was seen in some very elegant studies in orphanages in Romania, where kids were just left without much food, without much care, and many of them developed ADHD and other problems later on in life. But in addition to that, there are a lot of, we call them environmental correlates. If people look at the international consensus statement on ADHD, we talk about environmental correlates. There are various exposures during pregnancy from other smokes, for example, are kids more likely to have ADHD. But we don't call that a cause yet, because in fact, for smoking, what my colleagues have discovered is that turns out that mothers who smoke are more likely to have ADHD than mothers who don't smoke. And so what we thought was an environmental cause was actually a genetic cause, because we got fooled by what's called a confound. Mm-hmm. But we have a lot to learn about the environment, and that is, I think, the next decade of work is going to hopefully move us more strongly in that direction.
Now, my subjective feeling is that there has been a large increase in children who are diagnosed with ADD. Obviously, that's not scientific. It just feels as though it's more common to encounter children that have these ADHD diagnoses. And part of me wonders, it seems as though attention, especially attention to things that aren't of interest to a child, it seems as though attention needs to be fostered throughout childhood. It's something that parents, if they ignore it, it will just sort of spiral out of control. So you have to kind of, set up an environment that encourages your child to pay attention and to engage in activities that they don't want to do. So given that, is there a causal connection between the strategies that parents or the behaviors that parents engage in and the severity of ADHD symptoms?
Well, that's been looked into, because it was decades ago. Psychiatry was very, very fond of blaming the parent for almost everything. Parents were poor parents. Parents did this. Parents did that. Turns out that it's not the case that the parents of kids with ADHD are bad parents. It's the case that they have a very difficult child, and it's very difficult to parent. And in fact, when the child's appropriately treated with current treatments for ADHD, what we find is that the parenting skills get better, because now the parents have a more typical child, and they're able to actually parent the way the average parent can parent. Now, that's not to say that parents have no effect on their children. They certainly do. But we even find, for example, that therapies, there was a study that was done in the United States with several hundred kids, and they compared medication therapy with parenting therapy, meaning teaching parents to be better parents, with the combined therapy and with just nothing at all. And what they found was that essentially the medication had the best effect, and that adding the parent training didn't really help very much for controlling the ADHD symptoms. And lots of other studies have been done looking at parent training for ADHD symptoms, and it actually is not very useful for reducing symptoms of ADHD. It is useful for reducing symptoms of defiance in kids, oppositionality, bad boy type behaviors, if you will, bad girl type behaviors, um, but not so much for the actual symptoms of the disorder. So parents out there should know that if you have an ADHD kid, it's like any other medical problem. It's a problem that it's mostly inherited. It's not something that you cause. It's something that you can help by getting them proper treatment and engaging in that treatment as suggested by your provider. But don't blame yourself for your child having ADHD.
So I'm gonna I'm gonna definitely come back to the ADHD treatment story a little bit later in our conversation. Um, but I wanted to stay on this sort of childhood environment topic for a little bit. Um, I wanted your thoughts on the role of technology and how potentially it's overstimulating children. I know that. So if we assume that children with ADHD, they are capable of attending to things that interest them, right? It's not that
Mhm.
they cannot attend to it's specifically things that don't interest them that they have trouble regulating, but they can focus on a video game that they really enjoy very, very easily, or any activity that draws them in. I start thinking about things like tablets and smartphones, and how, is the exposure to those highly stimulating things just sort of raising the ceiling, such that by exposing them to tablets, that slowly makes everything else less interesting, right? Because in the same way that high sugar or high fat foods make other foods less palatable, I'm wondering your thoughts on if there's a role in technology in exacerbating the potential to see ADHD and have impairment.
Well, I'll tell you, every time there's a new technology, somebody says, this is causing ADHD and it's producing more cases of ADHD. And yet, when you look at the epidemiologic literature, the prevalence of ADHD hasn't changed over the decades. What, 4 or 5 decades since it's been measured. So, at least in that time period, changes in technology have not led to a dramatic increase in diagnoses of ADHD. And studies that have looked at, it used to be TV watching caused ADHD, but you know, that's not true. Uh, I don't think tablets are causing ADHD or smartphones are causing ADHD. You are correct, by the way, that children with ADHD can better attend to highly rewarding stimuli, such as tablets and smartphones and so forth. And so, yes, they're going to gravitate to those like other children, right? They're going to gravitate to those um, kinds of devices. And it does provide a challenge to parents, because parents have to kind of move their kids away from the places where they want to always be to attend to those things which are important in the life but aren't as rewarding. One of the biggest tasks for a parent with a kid with ADHD to make something that's not very rewarding more rewarding.
Yeah. So let's talk a little bit about what we know are effective treatments for ADHD. So obviously the first sort of line of defense I've seen is the stimulant medication. So people listening might know them as Adderall. Vyvanse is another one. I know that there's a lot of data showing the effectiveness of these medications.
Mhm.
However, there is a very clear narrative that I hear all the time, and it goes like this: I don't want to expose my child to powerful drugs. I want to focus on non-medication alternatives. How do you address that specific narrative?
Well, I'll give you an example of how I addressed it with a specific person who I won't name. It was her father called me up and said, "Hey, I think my grandson has ADHD, but my daughter keeps sending him to all these other kinds of treatments, taking vitamins, doing acupuncture, doing this, doing that, but not medication. Would you mind talking to her?" I said, "No, not at all. I'll talk to her." So I called her up, and she She indicated her concerns about medication. I understand why parents are concerned about that. And I said, look, here's what I suggest. Go to your pediatrician. If you find out first if the pediatrician agrees your son has ADHD, and if so, what the recommended treatment is. My guess is it will be a medication, and it was. I said, if it's a stimulant medication, the effects are sure your child will experience the effects pretty quickly. So, if you're worried about, you can only take it for 1 day if you want, or 2 days, or a week. I'd recommend you try it for at least 2 or 3 weeks, but give it at least a week. And then if you don't like it, you can stop. It's not going to be harmful in that very short time period. And she said, well, I guess that makes sense. Well, she did that. She called me back in a week. She said, oh my God, I wish I talked to you 3 years ago, because he's a different child now. Of course, he's a different child because he really did have ADHD and he was being treated appropriately. And so I tell parents, if you're worried about the potential adverse effects of the medications, you should start worrying more about the adverse effects of having ADHD, because you're not balancing these two things. The adverse effects you're worried about are actually not so bad. If you look at the FDA insert for ADHD, look at the clinical trials, the common adverse effects are very mild things like insomnia or loss of appetite. And those are usually pretty well addressed by a competent doctor who can change the medication or change the dose. On the other hand, the potential adverse consequences of ADHD can be enormous. I had another friend, a guy, actually, we used to meet at the bus stop, and I knew his kid had ADHD because it was very obvious at the bus stop. And finally he brought it up to me, and I explained to him what he could do in terms of medication and so forth. He wasn't interested. Fast forward, 15 years later, that kid was doing drugs. 20 years later, he was in jail. That doesn't happen to every child with ADHD, but it is one of the pathways ADHD leads to: substance abuse and criminality. And we do know from naturalistic studies that treating kids with medications for ADHD, particularly the stimulants, will reduce those kinds of adverse outcomes. So I say balance the adverse effects of medication with the adverse effects of consigning your child to a life with ADHD.
That's very interesting. I also hear, again, these aren't really based in reality, but you hear about this narrative of we're over medicating children, they're over prescribing, over diagnosing. And so it seems as though from hearing you talk that this might be overblown.
Yeah, I think it is overblown. In many cases, it's not always, but many cases by people who make money by scaring parents about ADHD. They have they have their own approach. They're going to sell you. Don't take medication, buy my book or buy my therapy or watch, pay for my internet site. And frankly, most of that stuff is BS. Most of it is, I shouldn't say most of it, it's almost all unproven information that is leading parents astray. I always tell parents, if they think somebody has a better solution, just go to pubmed.gov and see if they've written anything about ADHD. Just type in their name and see if they've written anything that's published in the National Library of Medicine about ADHD. Many of these people have published nothing. You want to see someone who's published, maybe 100 papers at least about ADHD treatment before you say, yes, I'm going to use their treatment. Most of these people never test their treatments, and they don't want to, because if they test them, they'll find out that they're not effective.
So sticking with this discussion on the medication, can you take a little bit of a deep dive into what these class of drugs do for the ADHD patient? How does it, what does it do for their brain that helps?
Sure. So there are two big classes of medications. You mentioned the stimulants. Well, there are also the non-stimulants. The stimulants work by this is Adderall, Ritalin, otherwise known as amphetamine or methylphenidate. They work in the brain by blocking the activity of a protein called the dopamine transporter. And by doing that, they improve the transmission of this chemical in the brain called dopamine. And by improving that transmission, they improve the ability of the frontal lobes of the brain to regulate the other parts of the brain. The non-stimulants work primarily, not completely, but primarily in the norepinephrine system. There are actually two different kinds of non-stimulants. Some of them block the norepinephrine transporter, which is another protein in the brain. Others work on a receptor called the alpha-2 receptor. And they have this similar effect in working in this, what we call the norepinephrine system or the noradrenergic system. And this system is well known for regulating attention and other aspects of behavior. As a general comment, on average, stimulants are more effective than the non-stimulants, which is why most people use them first. But many people do very well on a non-stimulant. And so those also need to be considered in a treatment, especially for people who are concerned about the stimulants.
Now, so you mentioned dopamine. I have a particular interest in how that, contributes to ADHD and how it relates to feeling pleasure in general. So we know that dopamine is this neurochemical that basically allows us to apply attention in a certain way. It contributes to our ability to take stimuli from our environment and sort of suppress it so that we can focus on other things. And I've seen that in many cases, people with ADHD will often fall into other behaviors that, whether within their knowledge or outside of their knowledge, help them achieve this goal in a similar way. So they gravitate towards caffeine or maybe even illicit drugs that help. Could you talk a little bit about behaviors that sort of manifest as self-medication, whether it's, drugs or other types of behaviors that they gravitate to help them
Sure.
function?
No, you're right. That will happen. And there are different drugs help in different ways. So people will go to caffeine for focus. Caffeine itself is not a very good treatment for ADHD, but everybody will all be a little bit more alert if we've had some caffeine than we haven't had caffeine. Some of the cigarette smoking in ADHD is probably self-medication. We do know that nicotine has a positive effect in ADHD symptoms. There's actually been some studies that show that, but it's a modest effect. It's not as big effect as the medications for ADHD. And in fact, when companies have tried to develop drugs that work on the nicotinic system, they have failed so far. So it's, although smoking, again, nicotine in cigarettes, for example, or in chewing tobacco, whatever, will give a person more focus. It's not the same level of effect as a treatment for ADHD. And then there's the drugs. People with ADHD the drug of choice for people with ADHD tends to be marijuana. And that does not improve focus at all. But I think for many people with ADHD, it helps them get to sleep, helps them relax. It has that other kind of effect in them, but not so much improving their symptoms of ADHD.
Yeah.
I do want to just make the point very strongly that, there's no street drug or no supplement that's going to dramatically help one with ADHD.
In the bit that you were just talking about, it got me thinking when you first mentioned that ADHD is broadly related to self-regulating. A lot of these, people with ADHD have trouble with what is known as executive functioning. I think some people kind of get a little confused understanding the impact to cognition and thinking versus the emotional piece. Could you talk a little bit about the internal experience of people with ADHD and what that's like?
Yeah, it's a great question. Probably somebody with ADHD can answer it better, but I'll try to do my best on that. I guess what I would say is, right now, you and I are talking on this podcast, and I'm listening to your questions and answering them, and you're hearing my responses and responding appropriately. Now, if we were trying to do this and there was loud music playing in the background, or there was periodic erratic sounds, or somebody all of a sudden lets out a scream, all of a sudden, our ability to concentrate and focus on each other would be impaired in that very unusual environment. For people with ADHD that are very distractible, that's kind of like their environment all the time. They're pulled away from what they're supposed to be doing. Like there's a magnet over there that's making them look at something else and not attending to what they're supposed to attend to. That's one aspect of the experience. It's this level of disorganization that they don't always feel as necessarily a problem at the time, but it's only when they reflect on the effects of what they've done that they realize it's caused them a problem.
So I still have trouble understanding why there is an emotional dysregulation piece to that. Is it the idea that the same executive functioning that allows you to pay attention to different things also is related
Uh,
to suppressing
uh, uh,
emotion?
Absolutely.
Okay.
Executive, one of the goals of executive functioning is to regulate behavior, cognition, and emotion. So think about, again, let's compare. Think of an example. You're driving a car, you're driving on the highway, and somebody cuts you off on the highway. Well, we all get annoyed with that, right? It really bugs us. We might swear, we might say something to our partner in the car, and we get a little bit upset, but we soothe ourselves, we calm down, we self-regulate, and we continue driving. Some people with ADHD, they can't soothe themselves. They can't bring themselves down very quickly. Instead, they get more upset, they get more and more upset, and they might, you know, slam the foot on the gas and chase the person. They might,
Mhm.
make a, they might try to cut the person off and get into an accident. The ability to self-soothe is an example of self-regulation that people with ADHD sometimes have a hard time. And I say sometimes because remember, ADHD is very heterogeneous, and so not everybody has every symptom class of the disorder.
Okay.
And also, I have to point out that in today's diagnostic manual, emotional dysregulation is not considered to be a symptom of ADHD. It's more of what we say it's an associated feature. It's common among people with ADHD, but it's not used as as a defining symptom. I personally think that's a mistake, but I didn't write the manual. I think that might change in the years to come.
So let's talk a little bit about ADHD in adults. Is is there is there anything of note that is sort of fundamentally different from, whether it's experience or treatments? Anything worth noting when discussing
Sure,
ADHD in
sure.
adults?
Well, first is that you know basically all treatments that work for kids work for adults, which makes sense. There is over time a, a diminution of symptoms, so that the symptoms of ADHD tend to attenuate over time. So an adult will show fewer symptoms, particularly the hyperactive impulsive symptoms. They tend to go away faster than the inattentive symptoms. The adult with the ADHD tends to be more disorganized, more inattentive, and less, frankly, hyperactive. Another problem that adults experience is that there are many adults with ADHD who aren't diagnosed until they become adults. They may have had a history of ADHD, which they need to have to meet the criteria, but because they've lived 2, maybe 3 decades or more with ADHD. Not only does their clinician have to treat their ADHD, they have to treat all the problems that were caused by the person not being treated. Because by having 3 decades of not developing life skills, that's more than ADHD. That's ADHD plus or skill development. And so
Interesting.
therapies, psychotherapies, cognitive behavior therapy can be very useful to help the person with ADHD learn some of the life skills they haven't learned. As we like to say, pills aren't skills. They don't teach skills. They only provide the ability to self-regulate and the ability to learn better.
So now, are you saying that? So let's say you have undiagnosed childhood ADHD. That could arguably make it very difficult to become an effective social entity. You have trouble socializing and making friends. Maybe that sort of relates to, maybe that eventually causes depression because your social life is not as strong as it could be. Um,
That's
is that
exactly
is
my,
that
that's ex-
something we see in the literature where you sort of see this branching off of, if you don't have self-regulation young, you sort of develop all kinds of other potential issues?
well, first of all, it's difficult to separate out the issues that would have developed anyway, because we
Right.
do know there's a biological link between ADHD and depression, for example, ADHD and anxiety. So in some cases, a person with ADHD will develop those disorders uh, because of biology alone. But there's no question in my mind that you consider the course of untreated ADHD, the low self-esteem, the effects it has on a person's social life, the effects it has on their ability to achieve in school, and later on at work. That's going to lead to a successive demoralization that's going to have a huge impact on them, on the way they feel about themselves and the way they feel about the world. And again, this is the reason why parents have to, and they think, oh, the risks of treatment, these risks of not treatment are very strong.
I've also seen in social media a little bit, there's a lot more self-diagnosis going on than there was probably 20 years ago with this, lots of social media influencers, and ADHD is just a flat out a hot topic on social media. Are you, I'm obviously, I don't expect you to be keenly aware of the trends in social media, but I am curious if there are conditions that by default people think are ADHD, but in reality there's something else. So for example, maybe specifically in adults, they feel like they have ADHD, they self-diagnose as ADHD, but maybe they just have depression, because we know that depression would also probably make it hard to focus on unimportant stimuli, right?
Absolutely. That's right.
What are the big conditions that could potentially in adults be misdiagnosed or improperly self-diagnosed as ADHD?
Well, I'm glad you made that distinction. So it's a competent clinician would never make this misdiagnosis, because the diagnostic criteria are actually very different. But you're absolutely right. Someone looks at social media, somebody with ADHD talking about their ADHD, and they'll say, oh, I've been depressed for years, and I have gender dysphoria, and fill in the blank. They say something else. The person's like, well, I have gender dysphoria, I'm depressed, I must have ADHD. Now, that's not unreasonable to think if you're the average person, but it happens to be totally wrong. It doesn't mean you have ADHD. It just means you happen to be depressed and have gender dysphoria. I would say to people who are self-diagnosing themselves, if you think you have ADHD, go talk to your doctor about it. Talk to somebody who is a licensed professional who can give you the answer and give you the most appropriate treatment. And if they tell you it's not ADHD, then maybe you should consider that you do have another problem. Now, I say that with one little caveat, and that is that there are some practitioners who don't know how to diagnose ADHD properly. And that's a conundrum, unfortunately, for patients. I've heard things I do some Ask Me Anything sessions on Reddit, where I get questions from Redditors about ADHD, and they talk about their experiences. And sadly, sometimes it's clear to me that they have a doctor or a psychologist that's not really competent in diagnosis. And so I also say to people, if you think that your doctor's not doing a good job, go to somebody else, because maybe they might be making a mistake as well.
I've seen a little bit about sex differences in terms of the symptoms of ADHD. Is there anything to that?
There is. The biggest difference is that boys in general tend to be more hyperactive, disruptive, impulsive than girls. So the average ADHD boy causes problems for someone else, teacher or a parent. That means they're more likely to be sent for treatment. So we know, for example, that in referrals to clinics, boys outnumber girls like 9-1. It's also true if you go out to the population and you actually do a research study and you measure ADHD in boys and girls, it's a little more common in boys. It's more like 3-1 instead of 9-1. But what happens with the over referral of boys is that many girls are missed early in the course of their ADHD. And sometimes many of them are missed until adulthood. And what changes in adulthood? Well, in adulthood, it's not the parent or the teacher that sends you to the doctor. You send yourself to the doctor. And so many young women start to realize they're having troubles in life, and they learn a little bit about ADHD. They go to get a diagnosis, and indeed they do have ADHD. So what we find is that in adulthood, the male-female ratio tends to become more 1-1. That's because females are referring themselves more to doctors.
Now, let's wrap up by talking about some of the non-medication related treatments. I imagine that there are some behavioral strategies that you could apply, whether it's we can differentiate between children and adults, but I've come across some content that suggests, for example, that because people with ADHD have trouble doing things that they don't like to do, you have to outsource the the motivation, through incentives or something like that. Could you,
Yeah,
as we
that's
wrap
right.
up,
No,
could you
yeah,
talk about some of these strategies
sure, sure. So
very
look,
broadly?
I was trained as a behavioral psychologist, and I know that behavior therapy can be very helpful to parents and children, no question about it. And for adults, cognitive behavior therapy can be very useful. In fact, when treating adults, those who are given cognitive behavior therapy plus medication do better than those without medication. Adding it on is useful. Uh, Now, the same thing is true for children. And the point I was making before is that the training parents to be better parents doesn't do a lot for the core symptoms of ADHD, but it helps some of the associated problems. And that's why you use it. So what I typically recommend is, you know, you see a doctor. If your doctor thinks it's appropriate, get on an appropriate medication regime. Do that until those symptoms are under control. At that point, you see how things are. In some cases, everything's fine and you don't need anything else. But in many cases, there are still problems. And then you figure out what's the best non-medical treatment that you can add on to it, help with those remaining problems. But the reason why I suggest that people try the medication first is that then you can see what you need to target with the psychosocial treatment. I think it's a more effective approach.
So you said medication appropriate. A clinician will determine if a medication is appropriate. What is going into that process to determine? So let's assume that there's a proper ADHD diagnosis, because obviously you mentioned that
Yes.
there can be
Right.
issues there.
Right.
But if you assume a proper ADHD diagnosis, what is a clinician going to evaluate to determine if medication is the approach?
So, well, one thing they'll look at is the age of the child. So, for example, the guidance from the American Academy of Pediatricians indicates that one should try a course of behavior therapy before using medication in very young children, preschool children, essentially. So that's one issue. What's the age of the child? Is the severity level of the ADHD might play a role. In some cases, the clinician will say, well, child has ADHD, it's not that severe. Let's try parenting therapy there first, see if that is useful. Those types of considerations come in now for adults, it's a little bit different. Or teenagers too, if a clinician is concerned that maybe this child might divert, misuse, or abuse a medication, then they might say, well, maybe I'm better off, not using a stimulant medication, but using a non-stimulant medication. So there are some reasons why, and of course, there's also medical checkup, right? So you're not supposed to give some of the ADHD medications for kids that have pre-existing cardiac problems. So the medical checkup has to clear the child for the ADHD medication first as well.
Okay. So back to the behavioral interventions. What are a couple different behavioral interventions, specific behavioral interventions that might be beneficial to children or adults?
Well, for adults, it's very clear. Cognitive behavior therapy is the only really evidence-based treatment that works well.
Oh, I see. I see. I was thinking more. Okay, so cognitive behavioral therapy would be the first that you would mention. How about sort of strategies at home, whether it's putting notes on things or
that's all part of cognitive behavior. So cognitive behavior therapy is
I see what you're saying.
Teaching self-regulation skills. And sometimes these are very concrete skills, like how to use a smartphone to keep yourself organized. Absolutely. So strategies, these become very important for people with ADHD when you've identified number one, what skills haven't they learned because of their ADHD? And what problems remain after they've been treated medically, then you give them these helpful hints, if you will, that are tailored to their life so they can improve their ability to self-regulate in these various domains.
Mm-hmm. Are there any, so I'm very interested in these tiny strategies that would fall under cognitive behavioral therapy. Are there anything that we know is sort of a waste of time something that, has been tried, but it's like, well, we don't really see that post-it notes on the refrigerator are helpful. I'm not really sure how deep the research goes into these behavioral strategies.
Yeah, that's something I don't have the answer to right there. Well, there's a lot of research in behavioral strategies. If you ought to invite Mary Salanto to give a talk to talk to her about cognitive behavior therapy. She's wrote a book on it, so she could tell you a lot about that for adults. Someone like Mark Stein would be great for talking about these kinds of strategies for kids. But the main point is that, yes, you can teach strategies. These are really important, but they're not going to help your child if you haven't been appropriately treated medically first. It's just that they're not going to help them as much, unless maybe it's a mild case of ADHD. But again, don't be afraid of treatment. Balance risks and benefits of both treatment and non-treatment when you think about that. That's a very strong message.
Well, that does it for us today. Thank you so much for being on. It was an absolute pleasure. Hopefully, both parents and adults with ADHD have gained some new perspective on this condition. Thank you so much for being on, Dr. Stephen Faraone.
And thank you for educating the world about ADHD. And I encourage listeners to visit me at adhdevidence.org.
For more on Stephen and his ADHD work, visit adhdevidence.org. If you enjoy this podcast, please share an episode with 2 of your friends. Follow the Why Do We Do That Facebook page for updates and additional content. Don't forget to rate and write a review on Apple Podcasts. Follow on Instagram at Why Do We Do That Podcast, or X, formerly known as Twitter, at WDWDTpod. As always, feel free to email me with comments or guest suggestions at whydowedothatpodcast@gmail.com. Until next time, this is Dr. Ryan Moyer, hoping you found some answers to the question, why do we do that?